If you follow the Inner Circle podcast closely, you will know that I have done an interview about breast implant illness. Laura Krosky bravely stepped into the Inner Circle to talk about her sickness, her decision to remove the implants, and her improved health that followed. Laura is not alone. Thousands of women are doing the same thing, traveling the same journey, one that's filled often with more questions than answers from this illness. Well, today I want to explore some of those answers and then, of course, go way, way beyond by welcoming a female powerhouse to the Inner Circle. She is a woman I have long admired and respected and is a wealth of information on this topic and way beyond. Dr. Lisa Korus knows a lot about busting through glass ceilings. She is the first female plastic surgeon to join the Division of Plastic Surgery at the University of Alberta in its over 50-year history. So can I repeat that? The first female plastic surgeon in Edmonton. That's a huge accomplishment, and we need to celebrate her for that. In addition to running a full surgical practice with a focus on breast surgery, Dr. Korus continues her interest in improving surgical outcomes through her research. She completed medical school and a residency in plastic and reconstructive surgery at the University of Alberta. Following that, she went on to take her advanced fellowship training, which focused on reconstructive and cosmetic breast surgery. Then she went on to complete a master's degree in public health from John Hopkins University. She also helped establish, among many other things in the city of Edmonton, Broad Day, which is Breast Reconstruction Awareness Day, and has recently joined the Professional Advisory Committee for the Hereditary Breast and Ovarian Cancer Society. Dr. Korus is passionate about improving the quality of care that women receive. I hear this from her all the time, providing women with options in regards to their bodies and about empowering them with the knowledge that they need to make the right decision for themselves. We've worked together on a number of projects, and I'm just so happy to have her step into the Inner Circle today, finally. Dr. Lisa Korus, wow, so great to have you here.
Thank you so much. I'm very excited to be able to sit down and chat with you today.
And we don't have coffee. I mean, usually we're meeting over coffee or something like that. That's to come. That's to come. Okay, you are joining me via Zoom. Is it from your home or from your office?
This is from my home right now because I think the internet is better here than in the office.
So why is she joining me from home? Because we are living in a COVID world where she is not going into her office every day and performing surgeries. But yesterday was your first day back. Was it doing surgeries in what, 2 months or something? Bring us up to date on where your practice is at.
Yeah, I think we are coming up on 2 months since we shut down. So 2 months ago, everything was kind of happening at once, and there was rumblings that they were going to at least slow down the operating rooms because they wanted to preserve resources, make sure we had space in the hospitals. But literally Tuesday morning, we got word that Wednesday we were shut down. So we were kind of having to cancel people, 24 hours notice. And then it's been kind of slow go since then, especially with most of what I do. It's not emergency surgery. It's, it can be delayed. But because we've been doing such a good job, I think, with flattening the curve here in Alberta, especially in Edmonton, they are slowly starting to open up again to elective surgery. So it was nice to have a day just to do, some breast reconstruction cases and, help those women complete their journeys because they've been, waiting for so long to get everything finished. But yeah, so it felt really good. Looking forward to when we get the next day. Not sure when that's going to be, but hopefully soon.
From a doctor's perspective, I mean, this whole COVID situation, what do you make of it?
It's scary in the sense that there's so much unknown. If you think about it, it seems because we've been also enveloped with it in the last little while, but it's been around for less than a year. And, in terms of actually doing proper research studies, understanding it, that takes time. And so it's only been a few months. So I think that's the scariest thing for people is that we just don't know. We say droplets spread, but then sometimes it could be potentially, aerosolized in certain situations. And so we're just trying to figure things out. in terms of how exactly it works.
I want to draw attention. Are you on a beeper or anything like that?
That's one thing I can't figure out how to shut that off without actually moving the whole computer.
It's all good. This is the world that we live in, and many of us are trying to navigate it right now. Something I would like you just to elaborate on, because this is your world, and you said something that a lot of us don't understand, is this takes research. Right? So can you explain that in layman's terms about what it means when we're dealing with a virus like this? And from a doctor's perspective, when you say this takes research, what exactly does that mean?
So again, it comes down to, in terms of doing quality research and high level research where we can actually prove cause and effect, really see, I'm trying to figure out the right words for it, but to do high quality research takes time. And we can see this right now with COVID. So very early on, there was these case studies and case reports, which are lower levels of evidence, that suggested that things like anti-malarials might benefit patients that are suffering from COVID. And then everybody got really excited about it, including the President of the United States. Yeah. But the problem is, until you do a properly controlled study, you rule out other variables that might be causing, people to improve, then you don't know for sure that those medications are actually delivering the benefit that you think that they are. And it's dangerous if you rely too heavily on poorly done studies, because you might be missing something else. And so we're learning about everything, right? And to do a properly controlled study it's not gonna happen overnight. And so we're trying to acquire information, I think, as fast as we can so we can treat COVID better. But at the end of the day, it's just going to take time.
Thank you for explaining that, because so many people just don't understand that, like you said, good research does take time. Because I think, I don't want to generalize, but one of the more popular questions out there amongst the population is, why is this taking so long? Why are we having to wait so long for a vaccine? What's the problem? And that essentially is the answer, right?
Well, exactly. To make sure that it's done properly, and especially too, if we're talking about interventions, so vaccines or drugs that we're going to be giving people, we want to make sure that they're safe, so that we're not causing more harm than good that we're potentially doing. So
I want to ask you one more question in this area before I move on. Your husband is a doctor, ear, nose, throat specialist. Is that right? Yeah. So what's it like for him? Is he back working? And, working in that particular area, if that's your area of specialty, like that's the source.
I know, exactly. Yeah. So it's been scary. There's a definitely more urgent nature to his practice. So he's been working a little bit more throughout all of this. But if you look at the literature, the ear, nose, and throat surgeons, I think, are the most likely to catch COVID, and they're most likely to die from COVID, just because the situations in which they're catching it, I think the viral load is actually higher. So, absolutely, it's been on our minds, and, making sure that we follow recommendations that are being put out by all our, the regulatory bodies in terms of proper PPE or, personal protective equipment and
so is he wearing one of those N95 masks? I heard that they cause bruising on the face. Are they brutal?
Yeah, I think if you wear them for a long time, because they need to create a proper seal against the face. And so that's different from just a regular procedure mask where it's not going to create that tight seal. So yeah, after wearing it for a few hours, it can get pretty uncomfortable.
Oh my goodness. All the respect in the world to both of you, and for everything that you're doing, working on the front lines in this regard. So I want to move on and dig into your story, because it's a rich one. And I just want to say that I want to do the happy dance every time I get to say that you were the first female plastic surgeon hired in Edmonton in 50 years. Let's celebrate that moment. But I want to begin here. Where did the interest in this career come from? Like, when you were a little girl, did you say you wanted to be a doctor when you grew up? Were your parents doctors? Take us back to when you were little.
Well, so it was, I think, in terms of the evolution of where I got, or how I got here, it was just one of those things. The more and more I learned about the career, the more and more interested I was. So growing up, I was always quite interested in science. So I knew I'd probably be doing something scientific. But I also like the human aspect of being a doctor as opposed to being an engineer or something a little bit more maybe dry compared to where you get to interact with people all the time. And then when I got into medical school, it was on the radar. I just thought it was pretty cool to be able to use your hands. And there's a whole quality of life aspect that plastic surgery deals with. So the more I learned about it, the more I loved it. And it just kind of progressed from there, essentially.
Did your parents have any role in planting seeds? I mean, what was the childhood like in that regard?
I think they're just supportive of whatever I was interested at the end of the day. We're definitely not a medical family. I was the first physician in the family.
Really?
Yeah, absolutely. And so but they always thought education was important. It was very important, that I got an education in whatever aspect of life it was going to be in. And so that was probably the biggest thing, is just making sure that I studied a lot. But yeah, they didn't really push me one way or another. They just wanted to make sure that ultimately what I chose, I was going to be happy with.
Okay, Dr. Korus, I need to ask you this question. And I know that you are like one of the most humble women I know, and you're going to try to shy away from it, but I'm going to put you on the spot. Like, honestly, we all know that one just doesn't wake up and say, I'm going to be a doctor. I think in many regards, you have to be a little bit gifted or like crazy hardworking, like super high marks, because this is two-pronged. The education, when you go through and do your residency, like it's brutal, and you have to have a few aces in your back pocket in order to make your way through that. And that's a lot of smarts upstairs, if I can use that slang. Did you realize that you had a bit of a gift when you were younger, that it was just that science and math and all those hard subjects came easy to you?
Well, I think it's the fact that I enjoyed them. So they took work at the end of the day, but I think if you enjoy learning those things, then it just makes it easier to do your homework and focus on things. I think throughout everything, I mean, obviously you have to have some smartness to you, but you also have to have drive, that at the end of the day, you just want to do better. You want to do the best. And I remember being in high school and, because you'd be like, oh, do you want a 90% average? But my math teacher was like, well, why aren't you aiming for 100? Like, why shoot any lower? And it was, you kind of take pause and you're like, actually, that's right. Why would you aim any lower than 100 if, you've got to set that as your goal and you've got to go for it. So I think at the end of the day, yeah, just having the drive, having resiliency and being a hard worker, and it all just came together.
Okay, wait, if you're going to open that door, did you get the 100 in math?
Not always, not always.
But sometimes.
But I was always aiming for it.
Amazing, Kate. I want to know what medical school was like and going to Johns Hopkins and all of the training. How intense was it?
It was pretty intense. I think the thing about medical school, so definitely you do well in high school and an undergrad to get into medical school, but then suddenly in medical school, you're in an environment with everybody else who is at the top of their class. And so that can be a little bit of a humbling experience because suddenly maybe you're not so special because everybody's special. But yeah, it was great. I did my medical school here in Edmonton at the University of Alberta, and they have an excellent program here. Yeah, and then too, so the master's that I did at Johns Hopkins, that was definitely, even just going to Baltimore was definitely, it's not what I had expected at all.
What do you mean by that?
So it was just very different from Edmonton in terms of, I think too, it's, such an urban city, right? And there's realities there that you aren't exposed to as much as you are here in Edmonton in terms of poverty. And I had no idea that they had one of the highest HIV rates in the United States there. And so the studies that I was doing there in public health definitely looked into a lot of the realities that the local communities face there. And it was an eye-opener, because it's not to say that we don't have poverty here in Edmonton, but I don't think to the degree necessarily that you see in some of those big urban centers in the United States.
Okay, so you're going through school. And at what point did you decide plastic surgery?
So again, I was kind of interested in it from the beginning, but I don't think I was all in until about my third year of medicine. And that's where you sort of need to decide, because you have to put together your applications for all the training programs. And so it was kind of that second last year of medical school where I kind of made the call that I was going to go all in, no backup plan. This is what I wanted to do, and fingers crossed from there.
Wow. Okay. Well, you definitely get to work with your hands every day, but tell us what happened when you declared that was the path you were going to go, and then you had to apply to it, right? Tell us the story behind that.
So it was pretty exciting, but it was very nerve-wracking, and it was actually interesting and part of that journey, because that's, I have to say my training in Edmonton was quite excellent, but leading up to that, so here you're stressed out because you don't have a backup plan. But actually, that's when I had a few people come up to me and say, maybe you should reconsider your application because this is not a career specialty for a woman. And I was so shocked to hear that.
Wait, people, is that men and women said that to you?
Men and women. So different people. One was actually a trainee in one of the training programs. And so you're hearing it from these sources. One was from the child of a plastic surgeon. And so you're kind of, you don't know where to take it because these people are, close to the specialty and I don't have a backup plan. And it was interesting because it was the first time that I'd ever even thought of being different as a female, is that there was something different. But both of them had specifically said, maybe as a female, you should reconsider your course because this is not a career choice for a woman. So that was kind of interesting.
I mean, honestly, what the heck does that mean anyway? Like women don't belong in plastic surgery? I don't get it.
Yeah, no, and at the same time too, I mean, because in Edmonton, they had never had a female staff person, you don't know anything otherwise, right? You're just like, well, maybe it's not. I mean, there are definitely plastic surgeons across Canada, but none that I had worked with directly. So I didn't have anybody to talk to in terms of what sort of different challenges you might face as a woman going through the specialty. But yeah, it was pretty interesting.
Did it serve as fuel to your fire?
Absolutely, because like I said, at that point, I didn't really have a backup plan. And so there wasn't really time to come up with one. But I think just going back to throughout all my studies, whenever I wanted something, I would just put my mind towards it. And so, I mean, at the end of the day, that can be their opinion, but they're not the ones that were sitting on the admissions committee. So
no. And that's what's so interesting is that females didn't belong for what reason, based on what? Because it was always a male dominated industry. And all of a sudden this big bright light called you comes into the picture. So I'm glad that it served you in that capacity.
Yeah. So exactly. It was it's not anything you want to hear, right? You already have a little bit of kind of nerves at this time in your life, but yeah.
Okay. Well, what about any female mentors during this process that you could have leaned on?
Yeah. So again, too, I mean, so I was fortunate enough to get into Edmonton, which was my first choice program. And I worked with excellent surgeons here, but none of them were female. It's not to say that they weren't good mentors, but there was always something, a little bit different because you wouldn't go with them to hockey games or, you wouldn't talk the latest hockey stats or golf stats. And so, there was always this kind of certain level of, you feel different. And it doesn't mean that they couldn't be, mentors for teaching me how to be an excellent surgeon. But yeah, there was nobody that really looked like me throughout my training. But then it was interesting. So after I finished in Edmonton and I went off to do some subspecialty training, that's when I actually did get to work with my first female surgeon. And I was so excited because I'm like, here's somebody that finally looks like me. And it actually ended up being quite a toxic mentorship. And so it was interesting because it was, it wasn't even just my perception because a few of my male colleagues had come up to me and, were like, should we write a letter? We see how differently you're being treated. And it was an unfortunate situation because I think at that point you realize that, you don't necessarily have to be a male to be a misogynist. And I don't know the root of where it comes from. I think sometimes for women, if they've, gone through harder times, they want to dissociate themselves from other women, especially in male dominated fields, because being around women might be viewed as a sign of weakness or, kind of having female qualities might be viewed as a sign of weakness. But it was fortunate after that, I did actually get a chance to work with some amazing female plastic surgeons. And so, they are out there. Would it have been nicer to maybe meet them a little bit earlier in my career? For sure. Mm-hmm. But at the end of the day too, I think I was able to take, some great learning from the surgeons here in Edmonton, even if they didn't necessarily look like me.
That's a great topic of discussion to look at it that way. And yeah, did you ever feel disadvantaged? Because, you do connect with colleagues on a different level when you can get outside the office and go to a hockey game or go out and talk about stuff other than your practice. It's the basic human connection. But were you invited to those things, or were you excluded, or what did that look like for you?
Yeah, I don't know that there was ever any intentional exclusion, but it just, yeah, you just wonder if there's a different level of connection. If, you kind of, I think I read an article with another female surgeon wrote, just like being involved in the locker room talk, right? So, a case, the guys go off to the male locker room, and then you go off to the female locker room with the nurses. And yeah, so it's just, it's different, right? At the end of the day. Yeah, but I mean, no situation's perfect. And then, exactly, my first female mentor, we didn't really connect on that level either. So it just goes to show, I guess you just have to take what you can from, the humans around you. And, I think it's caused me to reflect too, because at the end of the day, you kind of think, well, am I doing what I can to support other women that are coming up after me? And, maybe sometimes you don't, you get caught up in your head. And, so I think that situation has at least given me pause to reflect right now. And, we're fortunate if we look at the makeup of our program here in Edmonton. I think 50% of our residents are females, and, it's great to see. And so whether or not they choose to follow the path that I took or not, whether they view me as a role model or not, at least I can just try to be compassionate and help them get through things.
That's interesting. And since you opened the door to that point, I want to ask you, you must have female candidates now that are reaching out to you. Have you mentored anyone, and what advice are you giving them? Because I'm sure they look to you as you were the first in Edmonton. So are you paying it forward in that regard?
Yeah, I think so. I mean, one of the things that I really like doing is research. I'm all about research and science. And so I've been working on some really great projects with the residents. A lot of it related back to my interests in terms of breast reconstruction and breast surgery. And so I think that's kind of, nice just to show them ways to do science properly and, and consider the patients, right? What can we do with our research to make sure that we improve patient outcomes? So yeah, I don't know if it's more lifestyle mentoring, because again, too, everyone's going to choose a different path and what's important to them. But yeah, definitely, it's nice to be able to teach, and yeah.
Good for you. Curious what it was like when you started applying for jobs. I mean, in light of the climate that existed around you, what was it like? Like, I can't imagine.
Yeah, so going back to how when I was applying for residency, and being told, well, this is maybe not the career path for a woman, I really wanted to come back to Edmonton to work. And it was the same kind of thing, they'd never hired a woman here. And so I was, you kind of have those thoughts in the back of your head, well, are they going to? But at the end of the day, I think I was just kind of stubborn in how I had approached everything else in life, in that, this is what I wanted. And so I just made sure that I would do everything possible that I could in my control to make sure that I would get the job. So I didn't want to say at the end of the day, if I didn't get the job that I wanted, I should have done this. And so I did I did 2 fellowships, one in hand and wrist surgery, one in breast surgery. I started on the master's, and
oh my God.
I just worked on research, getting my CV built up, and, doing everything that I could. So I guess at the end of the day, that if it didn't work out, that I wouldn't have any regrets for it.
And let me hold space for all your accomplishments. I mean, come on, let's be honest here. You were like qualified and then some. So, I mean, you proved yourself in that department, that it's not like you were getting hired because you were a woman, or you weren't, or you were like, that was all irrelevant. Your credentials speak for themselves.
Exactly. Yeah. Yeah.
So, but you do say, now I'm gonna go to the opposite end of the spectrum with this, that being a female plastic surgeon is different. What do you mean by that? You've said that to me before.
Well, I think, yeah, so there's, I mean, many different ways you can kind of broach that topic. So I think the most obvious is in terms of family and having a family and family responsibilities. And so it's interesting to see how different people approach that. I remember going through residency training, not that it was a goal at that time anyways, but thinking, oh my God, I could never get pregnant. Everyone would be so angry at me because who's going to cover the service? Who's going to work as a resident, right? I mean, we didn't even take all our holidays during training just because, you know, you've got your obligations to looking after the patients. But then it's funny, when I went and did my first fellowship, there was a ton of the residents, and it was, so this is, you know, going from Alberta to Ontario, that were pregnant. And I was just like, what planet am I on? This is so strange. And then, you know, coming back to Edmonton, so some of our trainees have been pregnant throughout the residency process. And I think our program has actually been very supportive to them. But it's different because then you need to delay your training, you need to put things on hold. And then on top of that, you've got extra obligations when you go back to work. So when I was in training, I mean, your job is your primary obligation, and, you know, you get home when you get home and all the work is done. And so it's different if you have to, you know, consider childcare as well. So, I mean, that's an obvious thing, but also too, I find it's interesting, especially with my specialty, so dealing with breast surgery. Yeah. I think definitely I bring a different level of empathy to my patients. And it's not to say that men can't be breast surgeons. They can be excellent breast surgeons, but it's just different because I can talk to them from the perspective of, well, if this was my body, what would I choose? You know, and so yeah, so that kind of, I think it tailors your practice differently. And I think you approach things differently because of that.
Do you feel like you've been wholeheartly accepted into the club, so to speak?
Yeah, I think so. I mean, we all have our different things, and not all females are going to jive together and not all males are going to jive together. But I think in terms of, especially, you know, working here in Edmonton, we've got a pretty small group, and we're all very hard workers, and we've got each other's backs. And I think that's the most important thing, is just knowing, you know, if you get into a tough situation with maybe a crazy case on call, that you've got good colleagues behind you that, you know, can help back you up, and vice versa. So.
Okay, let's dig into your area of specialty, which one of them is obviously there's breast augmentation and reconstruction. I want to talk about reconstruction because it's an area I think that maybe a lot of people don't understand, and especially breast cancer survivors. So talk about your why there and why reconstruction is such a viable option for patients battling cancer.
Yeah, so that, I mean, breast reconstruction is a huge part of my practice. And it really comes back to those quality of life issues that drew me to plastic surgery in the first place. And so it's interesting because when I meet these women, they've kind of completed the life and death portion of their journey. So that's sort of done. And then they're just taking pause to reflect on their bodies, figuring out what their new body is going to look like in terms of, you know, their body image. And in terms of breast reconstruction, it's not for everybody, but it's definitely an option for women. And there have been studies to show that it can definitely improve your quality of life and your self-esteem after undergoing cancer treatment. Because to lose a breast is huge. You're losing part of your body. I hear time and time again from women about having to fuss with wearing these external prosthetics. They get hot, they get sweaty, they can fall out of their bra if they go swimming and things like that. So
just pause on that for a second. For people who don't know what you mean, what exactly, just spell it out for us, what external prosthetics means.
So, yeah, exactly. Just stuffing their bra. Once they've lost their breast, then they just have, you know, whatever kind of form. Some of them have like knitted balls, other are like these like external silicone things, but just something that they can stuff into their bra to simulate a breast. But it's not a part of them. It's just a Band-Aid essentially.
So in the reconstruction process, some people, and I know this because of my years back when I was a medical reporter at CTV, I covered this story extensively. First of all, I mean, if you have to have a mastectomy, one of your breasts removed, or a double mastectomy, I mean, this is a dramatic change to your body. I mean, in what other type of, like, there are some, but like you're removing two body parts, and what's left is what, Lisa, for people who've never seen post mastectomy, what does a woman's chest look like?
Well, it's flat, essentially. There's nothing there. And depending on the extent of the mastectomy, so, it goes on, it's not even like a male chest, because, you're really taking out all the breast tissue. So it can look kind of concave. There's a big scar going across the chest. Yeah, so it's definitely a drastic difference from having a breast there.
And then for the questions about why would reconstruction be necessary, you talked about the external prosthetics, but I mean, you look at women who lose their hair during their cancer journey. Like, these are elements of our body that contribute so much to body image. What are patients telling you about, when they go through reconstruction and the why that they want to do it?
Yeah, exactly. It all relates back to body image and how those things impact their self-esteem. And so being able to wear clothing and not look lopsided and to feel feminine, those things are huge for women.
What I find so interesting about this, and I want you to walk us through it in the simplest language that you can, with all due respect, doctor, is how do you make a breast? Like, what does this process look like for women who have gone through this? Like, let's say they've had a mastectomy and they're contemplating this, or just for general education. How complicated is this?
So the nice thing is we do have different options. So the simplest thing is just to use a breast implant. And so there's a variety of different ways that we can do it, but sometimes in an ideal situation, right after the mastectomy, we can put in a breast implant. Sometimes we need to put in sort of a temporary, we call it a tissue expander. So it's a balloon that kind of stretches out the skin, and then we can put in the breast implant. So that's the easiest way and the simplest way, because often it doesn't involve taking tissue from anywhere else in the body. So you don't have to harm another part of the body to make a breast. But then what we can also do is use the belly to make a breast. And so that's probably one of the other most popular ways that we use to make a breast. So people call it like a tram flap or a diap flap. And so we take kind of that spare tire, so you do have to have a little bit of extra tissue, and take it with its blood vessels and move it up to the chest. So we actually take out part of a rib, find some blood vessels that sit on top of the lungs, and then use a microscope to hook those blood vessels up together to give that piece of tissue blood flow in its new area. So yeah, so that's pretty cool. It's much more technical than using a breast implant, but it's also much bigger surgery. So that's not for everybody either, because you're asleep for the full day, you're in the hospital for about 5 days after, and it's a much longer recovery. So it's nice because you're using your own tissues, but it's definitely a bigger investment for patients in terms of time and recovery.
That's extraordinary. How long is that surgery?
So on average, probably about 8 hours. We tend to do it with a 2-surgeon team. But it's incredible. Just the time goes by so quickly because you're so focused during that surgery. It would never seem like it takes that long.
Oh my gosh, all due respect to you. I can't even imagine being on your feet and then staying focused for that amount of time. That's a long time.
Yeah, but I think I was thinking about it, it's actually kind of meditative in a sense, because you really block out the rest of the world while you're there and focusing and working on things. So yeah, again, it never really feels like 8 hours at the end of the day.
Wow. But the other surgery that you talked about, the tissue expander, is that painful?
It can be. I mean, what I've found with this is pain is so individual as well. So the big belly surgery is such a huge surgery, but it's incredible the number of patients that will go home after 5 days and only need like Tylenol. They don't need narcotics after surgery. With tissue expander reconstruction, yeah, if the skin doesn't stretch very well, if the skin is tight, if there's been a history of radiation, then it might be a little bit more painful. But really everybody's different, and it just depends on their tissues.
What about for some people who are critics that say, okay, wait, you're going to put a breast implant into a cancer patient? Couldn't that cause more problems? Your answer to that is what?
Well, so with implants, so the biggest thing is, especially when people are considering implant-based breast reconstruction, I always counsel women that implants aren't lifelong devices. They're foreign bodies, and there's things that can go wrong with them. And so you need to be aware of all those risks. And if you're okay with all those risks, then the surgery is for you. But it is an investment in the sense that, if you have a car, you're going to have to take it in for maintenance. Same with an implant. At the end of the day, it's not going to last forever. In terms of the evidence that we have for issues with implants, right now all the evidence is that they can only cause local complications. And that includes the one cancer that was associated with a specific type of implant. So that's probably important to touch upon because it was in the news a lot last year. So there's a specific type of implant that had been associated with a very rare form of lymphoma. And it was an implant that had a textured surface, and those ones have been pulled off the market. So that's not an issue anymore, other than the women that still have it in. There's not been a recall on implanted devices, but it is worthwhile talking to your doctor about the risks associated with that. But the standard smooth implants, whether they're silicone or saline, to date, we only have evidence that they can cause local complications. So you can get hard scar tissue built around them, they can break and things like that. So if you're aware of that and you're prepared to deal with it down the road, then it's a surgery for you. Some people will say, no, I never want to have to deal with anything again. And in that case, I'd say, well, that's probably not the surgery for you because it's not risk-free. So I think it's just important to understand the risks associated.
Okay, so I'm glad that you went down there as you did. And I know that this is a tricky subject for you to talk about as a doctor because you rely heavily on scientific evidence, and it's difficult to give answers when you don't have scientific evidence. But I began the podcast talking about Laura Krosky, who had her implants removed. And I now have another friend who had hers removed. There seems to be more and more women that are making this choice. And I know that on Facebook, I want to balance this, that there's like 100, or I don't even know, like 50, 60,000 women that have joined this breast implant illness group or something. Mm-hmm. Can you speak to that as to, and I know you're coming at it from a doctor's perspective, but what the heck is causing these problems? Or if you can't speak to that, there's so many women saying they have all these unexplained symptoms. So your professional perspective on what's going on there.
So basically what makes the topic tricky to begin with is we don't actually even have a true definition of what breast implant illness is. But if I were to best define it, it is a suggestion that implants not only cause local complications, but can be responsible for systemic illness. And so things that people talk about with breast implant illness include chronic fatigue, fibromyalgia, autoimmune disorders, and things like that. And so the issue that we have with breast implant illness in the science right now is most of the evidence that is talking about breast implant illness goes back to case reports and expert opinions, which, similar to our discussion kind of with COVID, it's sort of lower level evidence when you look at, we have a pyramid that looks at levels of evidence. And so it's a little bit lower on the pyramid. And when we've tried to do higher level studies, so more controlled studies with larger groups of women to look and see if there's any association between these things and breast implants, we have not been able to find a link. Mm-hmm. And so are there things we can't prove with science? Absolutely. So there could be the possibility that we just haven't proven this association yet because we don't have enough women in these studies. I think if that's the case, likely it's going to be an exceptionally rare entity, and there's probably more common complications to be worried about with breast implants rather than breast implant illness. But at the end of the day, it comes down to, are these women suffering? Absolutely. Can we say it's because of the implants? We cannot with the science that we have to date. But at the end of the day, if somebody wants to have the implants taken out, it is absolutely their choice to be able to do that. It's their body, and so they should have the control to do that. Obviously, understanding that having the implants taken out is going to be another surgery, and there's risks associated with that. But if you have a conversation with your doctor and your understanding of those risks, then absolutely you can have your implants taken out. Some women feel better after, and we don't know if that's because the implant or maybe even just having the surgery stimulates the immune system. The thing is too with these studies is, you need to control for the fact that people often feel more tired after aging 10 years, and are the studies controlling for that? The age group of women having implants might just be more likely to have autoimmune diseases to begin with. So there's so many factors that we need to control for in terms of better being able to understand this. And I think the scientific community and the plastic surgery community is receptive to this. We have to do more studies. We've got to keep learning about things, do longer term studies, better controlled studies as we start to understand this entity more. But yeah, so that's that's my take on it. These women are suffering, unfortunately, just with the evidence we have right now. We can't pin it on the breast implant. So if somebody comes into my office with these symptoms, I just have to say, I can't guarantee that any of the things that you're having are going to feel better after having the implants out, and you need to be okay with that.
Thank you for answering that. I know your dog is wanting your attention, so we'll just call that out right away. And that's one of a million reasons why I have so much respect for you, Lisa, is just that you will not just shut it down and say, no, there's no evidence of that, but that kind of empathy and compassion comes through that, geez, you know, we need to dig into this more. A couple more questions in that regard. When you talk about symptoms, I know you talked about chronic pain and fibromyalgia, but what other symptoms, if someone feels like, I know you've talked to patients about this, or women have come to you, not necessarily your patients, what are there common threads in the symptoms? Because I know in these Facebook groups, there seems to be. What are you hearing?
So I think the common thing would be is that the symptoms are actually rather vague. And that's what makes it difficult, because it's not like the cancer that we found associated with implants, although very rare, it was something very easy to define. You know, it would be the swelling. You could do a lab test that would diagnose it. So when I listen to women, it's these kind of generalized feelings of malaise and kind of joint achiness, but not really specifically any joints, of overall feeling tired. So again, it comes down to sort of those systemic things that seem to be affecting their whole body, but nothing that's really easy to kind of specifically define. And that's, I think, part of the problem is when you don't have a clear definition of what you're trying to chase after or look for a link for, then it makes it very difficult.
Right. I have read, and I would like your medical opinion on this, that sometimes, and like I said, just something I read, that the body will reject the implant because it's a foreign substance. Is there any truth to that?
So that's, yeah, in terms of actually rejecting the implant, I don't think that would actually exist. Well, I don't know, I can't say exist, but the materials that we use for the implants are pretty inert materials in terms of the silicone shells. So same material that we use in other implantable devices, you know, in terms of IVs, pacemakers, things like that. And so your body wouldn't reject it in a traditional manner, the way that it would, for example, if you have an organ transplant where it's got all, you know, these little antigens sticking up that the body's going to go and attack. So it wouldn't reject it in a traditional sense. You could get into a situation, for example, where you got an infection of the implant. And bacteria like to stick to foreign bodies. And so it could be one of those things you try to treat with antibiotics and it just keeps coming back and coming back. And so it's not that your body is rejecting it in a traditional sense. It's just, it's not clearing the infection because you have the bacteria sticking to the implant, is what we call a biofilm. So you could get in a situation like that where you might, you know, have women struggling with the implant and need to have it out eventually because of that reason, but you shouldn't reject it in a traditional sense.
One final question, and you talked about this a few times, where you said that implants, if you do go down that road, are not for life. You know, they don't last your entire life. What is a sign that maybe someone should go and see their doctor, that there are issues with the implants? Would there be symptoms? How would they know? Because I think that if women undergo augmentation, it's like, well, I got a new device for life, but that's not the case. So what are the warning signs there?
So it depends. In terms of the long-term complications, the things that we worry about the most are either implant rupture or capsular contracture, where you get a hard scar tissue form around the implants. If it's a saline implant, it's fairly obvious. If it breaks, it deflates, your body absorbs the salt water. So that's pretty obvious. But definitely with the newer generation of implants that we're using right now, the silicone gel, they're like a gummy bear. They're a cohesive gel implant. So it could crack and you might not know about it. So guidelines for that aren't really clear right now, but it's probably worthwhile if you've had your implants for about 10 years or so, maybe talk to your doctor about getting an MRI to rule out that there's not been an issue. But if the implant's cracked and it's been held within the scar tissue that the body's formed around it, it shouldn't really be causing you any problems. So you could be walking around and not know it. So regular screening would be useful for that. In terms of capsular contracture, it's nothing dangerous to the body, but basically the body just forms hard scar tissue on the implant and it can be uncomfortable and make your breast look funny. So in those cases, it's fairly obvious. And then I would just say go back and talk to your surgeon. In terms of treating it, we tend to cut out the scar tissue and just put in a new implant. So those are probably the most common long-term things. But occasionally, people will just feel sort of strange pain in their breasts. And if that's the case, talk to your family doctor and get worked up for a test. Most often it's actually because of the breast tissue itself being painful rather than a problem with the actual implant.
Okay. And can you finally just address, because I have you here and you're an expert, wasn't there like issues years ago with silicone implants? I remember reporting it on the news or covering it when I was an anchor. Like why do they still make silicone? Isn't it dangerous? And why would someone choose silicone over saline if they know that saline, if anything happens, they're not going to, be like compromise their immune system? So if you can speak to that.
Yeah, so it's kind of a funny story with implants if you go back in history, because when they first went out on the market, it was before, especially in the United States, before the Food and Drug Administration was responsible for looking at implants. So at first the FDA just looked at drugs, and so implants kind of snuck in onto the market without having to go through the proper testing that they would have to nowadays. And then what happened in the late 80s, early 90s is all these news reports started coming out of women feeling unwell. They thought it might be because of the implants, and the FDA looked back at the data and said, wait a minute, we didn't properly do all our testing with the implants, so that's why they got pulled off the market. After that, numerous studies were done. They kept on using silicone implants for breast reconstruction, but multiple studies got done, and they found that there was no link between the symptoms that women were experiencing when they got pulled off the market. So then they were put back on the market in 2006. So they do kind of have this funny history behind them in terms of how they were sort of put on the market at the very beginning. But nowadays they are probably the most heavily studied medical device on the market. And in terms of results, the silicone implants still will give the best result in terms of look and feel. If they didn't, I don't think that they would be on the market just because of all the controversies in the past. But yeah, the saline they don't tend to look and feel as natural as the silicone implants. So for that reason, the silicone is still on the market.
Gosh, you're such a wealth of information. I'm so glad that I asked that. Speaking of which, I'm approaching soon 50 years old in a few years, and I have been getting regular mammograms done, but what's the age? There's so much misinformation out there. If you go, and the worst thing that I do is go to Dr. Google, and I'm like, what should I be having? But what is the age? What should we be doing? It's hard to know the path. I thank God I have a great doctor.
Yeah, no, the recommendations behind screening can be quite confusing, especially as you start to kind of go deeper behind them. At the end of the day, it's probably best to talk to your family doctor because it's their job to be abreast on what the latest evidence is. But in Canada, it is recommended to start screening between 40 and 50. So they say routine screenings start at 50 years old. But if you look a little bit deeper into the guidelines, they did find a survival benefit for women to start screening at 40 years old. And so it's interesting is they're not recommending routine screening at 40 though, because you're also more likely to get false positives. So essentially something might light on your mammogram that's not cancer, but then you have to go for additional tests, additional workup, there's additional anxiety around that. So the guidelines try to balance for women in terms of, decreasing their mortality, but then not having them stress too much and undergo additional testing. So at the end of the day, I think it's important to talk to your family doctor about what's more important for you. If at the end of the day, you want to do everything that you can to decrease your mortality, then they might send you to start going for mammograms. If they explain, well, you might have all these unnecessary tests, people might say, well, it's not worth it then to start earlier on. So it is between 40 and 50, definitely starting at 50, but kind of in the 10 years before that, it's a little bit controversial.
Okay. Thanks for that perspective. I'm curious. I know that you do mommy makeovers. That's like the tummy tuck and the breast reconstruction, augmentation, all the rest of it. I'm just curious. I like to know these facts. What's the most asked question you get from women? What do women ask you more than anything? Is there a common thread there? I know that I've kind of put you on the spot, but what do they want to know about more than anything out there when they come to see you?
You know what, probably what we've been talking about for a lot of this podcast. In the end, probably we get most phone calls about breast augmentation surgery. And then the number one question is, are implants safe? So I think that comes up again and again and again. And it's one of those things, it's risk benefit, you know, so people feel great after having breast implants. It can really improve their quality of life, but they need to understand that there's risks involved. So I can't tell women that they come in that they'll have the surgery, they'll never have to worry about them ever again, you know, for the rest of their lives. That's not true. But if we have a conversation about, you know, what the science says, what the potential risks are, and their understanding of that, then, you know, they're empowered, and then they can make the decision right for them.
Lisa, I'm curious. I know that you never went down the path of having a family, but I can tell whenever you talk work, you just light up. Are you living your dream?
Yeah, I think so right now. It's kind of, you know, after so many years and not knowing what happens next, right? In terms of training, where you're going to get a job, but to have been in Edmonton now for a few years and set up a successful practice, it's been very rewarding. I love my patients. It's, you know, it's great to see the impact that you can make on people's lives. So that's been great.
Can you share whether or not, is there more on that medical bucket list that you want to achieve? Any other goals, Miss High Achiever?
We'll see. Right now, I'm actually, you know what, for the first time, instead of kind of looking at the next thing ahead, I'm just sort of enjoying the way my practice is kind of organically growing at this time. So just taking it in. Actually, it's nice to kind of take pause and enjoy things.
I think it's natural, and I mean, I certainly do this, that I look to women who have, you know, busted through the glass ceiling, and our city is full of them. And I've had, it's been such a beautiful gift to interview and share the stories of so many women like you who have gone down this path when you were told that you don't really belong in this field. For those women that are listening and need some empowerment, need some inspiration in relation to like what you went through in your journey, what do you want them to know? What can you leave them with in their heart and their mind today as they're listening, if they're going through a challenging time and they're not sure they can do it as well?
I think if you want something badly enough, just don't listen if somebody tells you no. You know, that was the thing. They're, you know, applying for plastic surgery and then having people say, you know, maybe this is not for you. You know, at the end of the day, I was like, actually, I think it is. So you have to have faith in yourself and your abilities too, because not everyone out there is going to agree with you. So I don't think you can necessarily, I mean, you have to listen to constructive criticism. Absolutely. You can't, you know, you can't block out the world, but not everybody's going to be right with their criticism. And so if it's something that you want, then you have to go for it. And then at the same time too, if it's something that you really want and it's not easy to get, then just don't leave anything, no I's undotted or T's uncrossed, right? You want to do everything that you possibly can. So in the event that it doesn't turn out, that you don't have any personal regrets that you couldn't have put more into it.
Well, you are certainly a shining example of that, of just going the extra mile in every regard. And one thing I have to say about you is I love your quiet confidence. You know, you're unassuming in so many ways. And then, like I said, I've heard you speak many times at Broad Day, and I've interviewed you. Then you get up to the mic and it's like, wham, you just ooze this incredible knowledge and perspective and empathy. I think that is one of your greatest gifts. And on that note, I want to thank you for stepping into the inner circle in the way you did. I know I asked you a lot of questions about that were not science-based, and there's nothing more uncomfortable for a doctor than to be asked those questions. But you stepped in with all you had and you educated us. So thanks for the impact you've had on this field and the lives that you are changing. I've talked to many women who have undergone reconstructive surgery at your hands, and they said it was life-changing. So Lisa, you're a gift, and your time and your story was a gift to all of us. Thanks so much for stepping into the inner circle with me today.
Thank you so much for having me. It was such a pleasure to chat with you.
And I do hope that life slowly gets back to normal, as I all do, for all of us going through this COVID crisis. We will manage this and get through this together.
Absolutely. Sounds good.
Thanks, Lisa.
Thanks.